Thank you for the invitation to speak, and the talks before were wonderful. Thank you so much. So I am going to talk on health disparities in healthcare, healthcare equity, and quality improvement in kidney disease. And I'm sort of pulling together a lot of my talks. So some of this folks have heard, but there's some new data. So I'm very excited about this. And there's a certificate program in patient safety and health and quality, and they started a new health equity part of that program. So we've been giving some lectures, and so some of the information is pulled from that. So I'll just go ahead and start. All right, so as you all know, Martin Luther King Jr. said, of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And he said this and he actually finished it by saying, because it results in physical death. And he said this in response to basically the segregation of patients and the University of Michigan, or at the Detroit Hospital here. And this is a diagram of the fourth floor of the Detroit Memorial Hospital, where Negro patients or Black patients were segregated. And this hospital received federal funding, and he just reiterated that inequality and injustice in healthcare is really the most shocking and inhumane. And as you know, there's this legacy of mistrust in the US, particularly for the African-American community. And this is really due in part because of all the things that have gone on in medicine, but in part because of this study, this Tuskegee study, where African-American men thought they were being treated for syphilis, but they were really being observed, and complications of syphilis were recorded. And this study went on from like the 30s up to the 70s. And there's also a legacy of mistrust due to sickle cell testing of newborns in programs where people were affected by having a diagnosis of sickle cell disease. So given that history, the objectives of my talk are to review the intersection of quality improvement and health disparities, to really describe social and biologic determinants of health and how they can affect the development and progression of health disparities, discuss some potential interventions that have shown to decrease health disparities and complications in chronic kidney disease, and then maybe to summarize some approaches that might be used to help decrease health disparities, and sort of in this lens of chronic kidney disease. So the quality of healthcare and disparities in care really sort of align with what the Institute of Medicine defines as quality. And the Institute of Medicine basically said that there are 6 pillars that we need to really evaluate, and that care needs to be safe, it needs to be effective, it needs to be efficient, it needs to be timely, and it needs to be patient-centered. And I say that it needs to be equitable as the forgotten pillar of healthcare. And equitable means that unequal treatment should really be a thing of the past. Disparities in care should be eradicated, and that the metrics that we use should be that there are quality differences that are measured by race or ethnicity or gender, income, and by the social determinants of health. And as Laura's talk showed, there's still a lot of inequity in terms of homelessness and access to care. There are still health disparities in many aspects of medicine that we provide. So almost 20 years ago, the Institute of Medicine came up with this book called Unequal Treatment, which was confronting racial and ethnic disparities in healthcare. And I think that we still have a long ways to go. But looking at the intersection of health disparities and quality improvement, when you search on that, there are a lot of articles out there now that are looking at this, but very few that look at it for the intersection of quality improvement in kidney disease. So to go over a few definitions. So health disparities is really racial and ethnic differences in the quality of healthcare. It's not due to access or clinical needs or preferences or the appropriateness of the intervention. And again, this is almost 20 years old, so we may need to sort of redefine these definitions. And discrimination in healthcare is really differences in care that result from biases, prejudices, stereotyping, and uncertainty in clinical communication and decision-making. And so back in 2002, the Institute of Medicine basically came up with this way of looking at health disparities, and showed that, differences between what minority versus non-minority populations get can be the clinical appropriateness or patient differences, but a disparity is really something that is different because of the healthcare system or because of discrimination. So that's something that we should keep in mind. And typically these are in populations with equal access to healthcare. So why is this important? Because health disparities really cost us quite a bit of money. So this is an older study from 2009 that looked at the costs of health disparities, and the excess healthcare costs for minorities compared to whites accounted for about 30.6% of costs from 2003 to 2006. And this was based on the Medical Expenditure Panel survey. And I suspect that these costs are probably more. And that if we could prevent racial and ethnic health disparities, we would reduce medical care expenditures by $229.4 billion. And if we eliminated those disparities and premature death, we could probably save an estimated $1.24 trillion. So, we could really pay for a lot of the health care that we give. And again, I suspect that cost is more now since these numbers are old. So how do we really look at quality improvement and effects on disparity over time? So this is a paper by Green and colleagues where they tried to basically look at how health disparities, how a quality improvement project might affect health disparities. So it can either increase the disparity, it can decrease the disparity, or the disparity is maintained. And so for the rest of the talk, I'm going to go through examples of that in our literature and present some data from one of our studies at the VA that shows this as an example. So just to show this a little bit more sort of clearly, so a disparity can be increased if you have like a quality improvement program. You have a goal for your quality of care, and comparing your minority population to the majority population, you can increase the disparity. Even though things may be getting better for everyone, it gets better for maybe the majority population compared to the minority population, and so the disparity may be increased. Similarly, you can have sort of the start of a quality improvement program. You have your goal, it's attained for the majority population, but the disparity is maintained, and I'll show you examples of that. And then finally, which is what we're really targeting, is that you start a quality improvement program, you have your goals, and the disparity is decreased so that everybody, all of the quality improves for all of our patients. Okay, so as nephrologists, we actually know a lot about quality improvement because dialysis is something that is highly regulated, and we are basically paid and penalized for the quality that we give to our patients. So prior to dialysis, there are some metrics that aren't really, that we're not really sort of held accountable for, which include education for renal replacement therapy, whether or not somebody gets a preemptive transplant, whether or not they've had their access placed. It's something that we strive for, but we're not really penalized for it before people start dialysis. Whether they're getting appropriate treatment, whether it be ACE inhibitors or SGLT2 inhibitors. We want to treat acidemia, we want to treat anemia, and we want to evaluate for heart disease. So those are things that we really evaluate in people who are approaching dialysis. And once people are on dialysis, then we actually do have the QAPI meetings that occur in the dialysis units, which are our quality assurance and performance improvement, where we look at our dialysis metrics. We really try to drill down on what's going on with our dialysis population, and we really try to improve anemia, adequacy, or to get rid of our catheters and get people transplanted. So we know a lot about quality, but I think as a profession, we haven't looked at it with a lens of sort of equity. And so, as you know, chronic kidney disease affects well over 26 million Americans, and Blacks and Hispanics and other minority groups have a much higher incidence and faster progression of kidney disease to end-stage renal disease. And African Americans or Blacks represent about 30% of the population, but about, or 13% of the population, but about 30% of those who are on dialysis or in dialysis units. So, just that we know that many of our minority groups are overrepresented in our dialysis units. We really think that social determinants of health play a role in chronic kidney disease. And so these social determinants of health include like the neighborhood and the built environment, health and healthcare, social and community context, education, and economic stability. And I will refer you to Dr. Hall's review, and we're quoting Dr. Hall a lot this morning. So this is a great review where Dr. Hall reviews social determinants of health and how they are associated with kidney disease. And these are the main social determinants of health. Again, you know, economic stability, which includes income and employment and access to food and housing, education, which is our language and literacy and early childhood education, neighborhood and our built environment, which includes housing safety and access to nutritious food, and, you know, transportation and social and community context, which includes where we put sort of mistrust and community engagement, segregation and discrimination, and then health and healthcare access, which includes insurance and access to healthcare systems. So in Dr. Hall's review, he says that social determinants of health really account for almost 60% of sort of the contribution to chronic kidney disease. And 40% are behavioral patterns, 15% are social circumstances, and 5% environmental exposure. And it's really like 10% is thought to be healthcare and 30% genetic predisposition. So there's a lot that maybe can be intervened on that can help to decrease chronic kidney disease. And this is his conceptual model of social determinants of health and kidney disease. And so you can see that someone's socioeconomic position really has a sort of very close relationship to their social class and to race and ethnicity, which can affect their education, their occupation, and eventually their income. And sort of these intermediate determinants of health include material conditions and biologic factors and psychosocial factors. And these can affect the development of chronic diseases such as obesity, hypertension, and diabetes, which are the largest risk factors for kidney disease. And all of these are affected by our healthcare system. And you know, these are some of the things that we might be able to intervene on. We can also intervene here, but we're already sort of in the place where people may already start to be progressing to worsening kidney disease. So I'll go over now a few examples of sort of health equity examples and where we stand. So this is looking at racial and ethnic differences in diabetes complications in systems where people have equal access to care. So these are older data that we basically did that include data from the VA and from group health. And they basically show that there are racial and ethnic differences in early development of kidney disease in this population that has equal access to care. So Blacks and Asians and Hispanics still had increased albuminuria compared to whites. Again, these are data that are probably about 15 years old now, that persisted in a setting where people had equal access to care. The same thing was we found in the VA, and we found the same thing when we looked at other complications of diabetes. So this is an example of how health disparity is maintained over time, with your intervention being equal access to care. So heart disease deaths have been shown to be increased in African Americans compared to whites, and so this started in the 80s and has continued, and so the mortality rate ratio is really higher for Blacks than whites. So we did some, and this is an example of how health disparity has increased over time. So we looked at data from the USRDS and looked at MI rates after initiation of dialysis back in 2006. And it showed that if you looked at African Americans, Asians, and Hispanics, that once they started dialysis, the rates of MI were definitely less than that compared to whites. And it was, they were decreased whether or not people had prevalent or not, had no prevalent chronic or cardiovascular disease. So this was an example of how health disparity decreased over time with the intervention being dialysis. And presumably this may represent that people actually have access to care and they're being seen more frequently. So they have decreased complications, but it's probably more complicated than that. So as we all know, the incidence of end-stage kidney disease is greater in racial and ethnic minorities compared to whites. And it helps to look at sort of the incidence rates by race in the US over the past few years. So the USRDS started to collect data basically in the end-stage renal disease program started in the 70s, and data started to be collected in the late 70s. And African Americans have always had this higher incidence of end-stage renal disease. Native Americans had also a very, very high rate of end-stage renal disease, and then it started to decrease right around the year 2000, and we'll go into why that possibly happened. But the rates of end-stage renal disease are just very high for African Americans. It starts about 10 years earlier compared to other populations, and then there's this continued sort of disparity in terms of cumulative incidence of end-stage kidney disease for men and for women. The graphs look very similar for women. When people start dialysis, as I said before, we do a lot in terms of quality of care. And so Seagal looked at this in 2003 to see whether or not our quality of improvement programs in dialysis actually affected improvements in certain aspects of dialysis care. So this is a graph that shows that when these programs were instituted, that there was a little bit of a decrease in the disparity of access or adequacy in dialysis over time. And so it doesn't look like there's that much of a decrease, but there is a decrease in there are more Blacks who have adequate hemodialysis by dose. As opposed to changes in hemoglobin, this graph was supposed to represent that there were fewer changes in hemoglobin over time during this time frame. So this was a example of how disparity stayed the same over time. And it would be worthwhile to actually take a sort of broader view of this to see if these have improved over time. And so I'm going to come back to this graph that looks at the trends in end-stage kidney disease incidence rate by race in the US population over time, and take a look at this graph for American Indian and Native American population. And so this is an example of how disparities decreased over time for our indigenous populations here, but not for Blacks. And we think that the reason for that is that there was a comprehensive kidney care in the Native Indian Health Service that was implemented, where interdisciplinary diabetes program was initiated that targeted people with kidney disease. And so it's thought that this systematic intervention decreased diabetic end-stage renal disease by 50%, and it included routine eGFR reporting, urine albumin monitoring that occurred annually, use of RAS blockers and aggressive blood pressure control, and enhanced patient and provider education and access to a nutritionist and dietary information. So these are all the things that we know at the time knew that would help to decrease progression of kidney disease. And if they can be enacted in our populations, then they can actually decrease the incidence of end-stage kidney disease. I'm going to tell you a little bit about the VA ECHO telemedicine program. So this is another example. So we know that nephrology care is difficult to provide, especially for rural and medically underserved areas. and the VA provides care for over 8 million veterans at a cost of probably more than 50 billion now. 41% of these veterans live in rural or medically underserved areas, and about, I guess, maybe 6 or 7 or maybe 8 years ago, the VA implemented the Specialty Care Access Network's extension for community outcomes, or the VA ECHO program, that initially Raymond helped to run, and then Maggie ran, and now Steve Gorbakin is running. And the VA Puget Sound received a grant to implement this program in specialty care. And we've been running this program for a long time, but we haven't really evaluated how that implementation actually improved nephrology care. So we came up with a study to really try to do that. So we looked at patients who had been exposed to VA ECHO in VISN 1, which is on sort of the Northeast, and VISN 20, which is our VISN. So we had providers who had been exposed to basically our teaching of nephrology care to primary care providers. We excluded the attendings who didn't identify as clinicians and really had no patient care. We then matched these providers with unexposed providers, and then we looked at the patients from the ECHO exposed providers and compared them to the patients from the non-ECHO exposed providers. And VISN 1 is basically here in the Northeast and had access to all of these different sites. And in VISN 20 had access to similar sites, but included Alaska and Hawaii as some of the providers who were included in the sites that were included. So what it showed, which is really amazing, is that if providers were exposed to VA ECHO, it really slowed the initiation of dialysis and improved survival in veterans. So those providers, patients who were exposed to VA ECHO had a decreased incidence of dialysis by 38%, and an improvement in survival by about 25%. So, and when we looked at sort of all-cause mortality, all-cause mortality was also decreased for Blacks and for Hispanics and for the rural population. But when we looked at whether or not end-stage renal disease was affected, so it wasn't really affected for the Black veterans, but it was for rural veterans. So this basically showed us that for mortality, there was an improvement, but for end-stage renal disease, there was definitely an improvement for rural veterans, but probably not for our Black veterans. So that's an example of an intervention that actually improved sort of end-stage renal disease. And I think this is my last example. So there have always been health disparities in access to kidney transplant. There have been long wait times, and people of color have had decreased access to kidney transplants. And there are lots of studies that have shown that, you know, there are lots of places where people are sort of hung up in the system and really don't have access to kidney transplantation. So in 2014, the kidney allocation system was developed and really tried to target increasing equity for access to kidney transplantation. And so one of the main factors that was changed was the time on dialysis was taken into account. And so the transplant nephrologist, I know that I'm taking a very simplistic view of this, but you can talk about it when we have questions. So how did this affect transplantation access primarily for people of color? So you can see very clearly that in 2014, when CAS was implemented, that the rates for kidney transplants really decreased for whites, but increased for Blacks and Hispanics, and sort of leveled access to transplantation, which is just striking. And you can see here with some data that's a little more data that has been maintained over time, even though there's differences in the number of patients who are waiting on the kidney transplant list. And this is, so how did the kidney allocation system change the trends in preemptive kidney transplants? So preemptive transplants really are people have access to once their EGFR is less than 20. And so pre-CAS, there are about 9% of patients who received preemptive kidney transplant. After CAS, it was about 9.8. So there were more people who got preemptive transplants. And if you looked at Medicare versus private insurance, those with private insurance were more likely to get transplanted. And if you looked at differences by race and ethnicity, basically there was no change. So Black and Hispanic patients were still much less likely to receive a preemptive transplant compared to whites. So for preemptive transplantation, the caste system really didn't make a difference for equity issues. And this is sort of the longer term follow-up that whites still receive preemptive transplants more than Blacks or Hispanics. So how do we leverage quality improvement to improve healthcare equity? And so you can identify disparities to guide interventions. And so we really do need to collect race and ethnicity data, language data, social determinants of health, sexual orientation and gender identification data, stratify quality data, identify disparities so that we can intervene on them, identify barriers to care for specific disparities groups, by having focus groups and interviews and informal communication with staff. And really, we need to engage our communities. And to address some of the common barriers, we had to really address communication. So interpreters that are, and having language concordant providers, navigators may be useful, coaches and community health workers are not really proven in kidney disease care, but maybe something that needs to be studied or needs to be implemented. Our care needs to be patient-centered, so we need to simplify our appointments and have flexible hours and peer support networks, and make sure that conscious and unconscious bias are not involved in our clinical decision-making, and using evidence-based guidelines and physician report cards for our processes. So I will end with equity is the forgotten pillar of quality. Minority groups, BIPOC, people of color have many health disparities, especially in kidney disease. The social determinants of health still play a role in the incidence and prevalence of kidney disease. And we know that there are efficacious clinical interventions that can decrease disparities, and targeted interventions can really help us decrease health disparities. So I think that's it. So thank you very much.
Thank you so much, Bessie. We have time for a few questions or comments from people. Susan?
Hi, Bessie. Thanks for the great talk. I was really impressed by the scan echo results, and it's very pleasing. I just wondered in your adjusted models whether or not you included any facility level or VISN level characteristics, because I wonder whether or not scan echo is part of a broader package of care that that particular institution is doing to reach out to underserved veterans.
Right, so it was a matched cohort study, so really tried to match on a lot of different aspects of the facility. So we tried to do that with the matching because it was just, we really had difficulty trying to figure out how could we evaluate scan echo in a way that really portrayed what was going on with these different systems. So Scan Echo had like 5 different programs that were instituted across the country, and we felt that VISN 1 and VISN 20 were the most similar. So that's why we used those 2, but tried to match on what we could.
Sarah?
Thanks, Bessie. So another question about VA Echo, which I'm impressed with those findings. That's actually really cool. And the people working on that project should be really proud of themselves. But I had a question. I know you showed that among rural patient providers that patient outcomes improved. Were you able to break that down by race, since in the overall?
So we haven't done that by race, and I think that's one thing that we should do. So exactly, that's something that needs to be done. So, and I really do want to give credit to Raymond Pitchler and to Maggie Fleet, because they are the ones who ran that program. And every week they spent time, talking with the primary care providers, answering e-consults. And, people just didn't know if it made a difference, but I'm hoping that, once we get this out and show that it really did make a difference. So kudos to you two. And now to Steve.
So maybe one final question from Steve before we close.
Yes, Bessie, my question deals with daily activities on the wards, because you mentioned the importance of documenting race and ethnicity. And I think years ago, everyone would document race in the chart and make it part of their presentation. But what's your feeling currently about, on our daily notes and consults, do I identify race? And when we have a medical student and a resident present a patient, should they include race in their presentation or not?
So I guess the question is, why are you including race and ethnicity in the presentation? And I think that that's, we were trained to include those because we thought that they affected, how people presented. And probably what that represents, I would say, what I believe is that we need to be presenting more of sort of the social determinants of health that bring people into the hospital, and less race. So race becomes this variable that includes lots of different things, but doesn't necessarily reflect what it really should reflect, which are probably the social determinants of health. So I think in medicine, we've gotten away from including race because the thinking is that really it's all of these other things that are the variables that are affecting, whether or not somebody has a higher risk of disease.
Okay, thank you.